Hi, everybody. Thank you very much for joining us today. This is the last webinar of Webinar Week in our Macular month, so we're very happy you can join us. We're also very lucky to be joined by Dr. James Wong, who's going to be taking us through the treatment landscape, current and emerging therapies. Before I go on, I would like to acknowledge the traditional custodians of the land on which we are meeting today and pay my respects to elders past, present, and emerging. Before we go on, I would like to go over a little bit of housekeeping. If you can hear me and if you can see me, that's great. That means you've been able to access the webinar. If you are having some IT issues, please try refreshing your page. If that doesn't resolve the issue, you can give our helpline number a call, which is 1-800-111-709, and someone will be able to help you out. You might notice that your microphones and videos have been turned off. This is because we do have quite a few people in attendance. However, that doesn't mean you can't interact with us. You can still ask questions. And I just have a little screenshot on the screen of how you can do that. So towards the bottom of your screen, you might be able to see a black bar. And on that black bar, there may be some icons. So there's a chat icon, a raise hand icon, and a Q&A icon. So if you select the Q&A icon, that is going to bring up a white box. You can type in your question in that white box and then select send. Just to let you know, only myself and Dr. Wong will be able to see those questions. So don't be afraid to send any questions in. If you would like to send them in anonymously, you can definitely do that just by ticking send anonymously at the bottom of the white box and then selecting send. If you could keep your questions quite general in nature, that would be very appreciated. If you are having some IT issues, please try not to pop the IT issues into the Q&A function, just in case we don't see it in time. Rather, it would be great if you could please ring that helpline number, which again is 1-800-111-709. You might also be able to see a leave meeting button at the bottom of your screen. This allows you to leave the meeting, so don't click on that one just yet. So that does bring me to the end of our housekeeping. And again, I would like to introduce everyone to today's webinar, which is about the treatment landscape, current and emerging therapies, presented by Dr. James Wong. Dr. James Wong is a medical retina ophthalmologist, a medical eye specialist focusing on disorders of the retina and macula. Dr. Wong is a consultant in the Medical Retina Unit at Sydney Eye Hospital and a clinical lecturer at the University of Sydney, regularly teaching medical students, ophthalmology trainees, optometrists, and general practitioners. Dr. Wong is a medical director of Strathfield Retina Clinic and co-director of research of the SRC Research. For over a decade, he has been a principal investigator on multiple international clinical trials for macular and retinal disorders, including age-related macular degeneration and diabetic retinopathy. So, Dr. Wong, I might get you to pop on screen. Thank you so much. And you can share your screen there. Perfect. That looks great. Well, thank you so much for being with us, Dr. Wong, and I cannot wait to hear what you have to say.
Great. Thank you so much, Delaney. Thank you, everybody, for attending this afternoon's webinar, and thank you so much for the Macular Disease Foundation Australia just for the invitation to speak. As you know, the MDFA do amazing work, and just encourage them to keep on doing all their incredible support, advocacy, and just basically being out there, just being people, making people aware of what's going on. So today I'm going to be speaking about the treatment landscape, current and emerging therapies. This is a bit of my talk overview. I'll be talking about macular degeneration in general, and then I'll be talking about wet macular degeneration, some of the current treatments, some of the new treatments, and some of the emerging treatments and trials, and move on to the dry macular degeneration with current supportive treatments, some of the new and emerging treatments, and finally finish with some about diabetic macular edema. Please do not hesitate to put some questions, as Delaney was saying. These are my financial disclosures. And look, you all know that the eye is an amazing organ when it works well. It's like a camera, and we have a lens system in the front and a film at the back we call the retina. The macula is a very central part of the retina. It's a really important part that we use for lots of daily functions. This is the normal retina. We can see there's a round thing, the optic nerve, connecting our eye to the brain, and there are some nice retinal blood vessels there. What is the macula? It's the central part of the retina. It's an important part, about 5 millimeters in diameter, and it's a yellow color. So what's the macula important for? We use it for driving, for reading, watching TV, and watching and recognizing people's faces. So unfortunately, when we get older, some of us can get age-related macular degeneration, where effectively there's wear and tear in that macular area. You know, there's some risk factors for macular degeneration. Aging is number one. We also know there's a family risk as well that can be passed through the generations, not always, but can be. We know smoking and excess sunlight or UV light exposure can be implicated as well, and a poor diet is also a risk factor. So unfortunately, we can't stop aging. So I found this cartoon of an anti-aging cream. It's the cream, you rub it onto the mirror. It won't remove your wrinkles, but it will make them harder to see. So it's not a bad strategy for anti-aging. So what about dry macular degeneration? We know there's a progression in some people can go from an early to an intermediate to a late. This little slide just shows what happens in the early stage, where we get these small yellow spots here, we call drusen. They can increase in size to become an intermediate size here. And that can lead to a late stage we call GA, or geographic atrophy. Along this journey, which not everybody goes on, and not everybody goes from early to intermediate to late. Some people never progress from the early to the intermediate stage, and likewise from the intermediate to the late. Somewhere along the way of this journey, people can get an offshoot we call the wet macular degeneration, where there is neovascularization or new blood vessels causing a more damage in the macula. So this is an example of an early-ish dry macular degeneration with yellow spots we call drusen. This is a bit more, we call intermediate dry macular degeneration. And this is the advanced dry macular degeneration that we call geographic atrophy, or GA. This is advanced macular degeneration, or the wet time. We have different names, also choroidal neovascularization or macular neovascularization, where there is acute bleeding or hemorrhage here. This little video just shows what can happen in somebody when they start off with a healthy macula with no spots. Then they can get some small drusen and increase in size, and this then can lead to the wet macular degeneration. Sometimes even the dry macular degeneration can cause vision problems. If it gets to the wet stage, often this can cause significant problems without treatment. So what are the treatments we have for wet macular degeneration? These are the anti-VEGF or anti-VEGF injections. What is VEGF? It stands for vascular endothelial growth factor. What is VEGF? It's the predominant growth factor in angiogenesis, or development of new blood vessels in the body. And a lot of these vessels in the eye, as well as the rest of the body, are stimulated by this hormone. It's like a hormone. They can grow in the retina, and we call it retinal neovascularization from diseases such as diabetes. That it can also happen underneath the retina in what we call choroidal neovascularization in wet macular degeneration. A lot of the work that we've, all the treatments we have now are based on cancer work. So before we had these injections for the eye, there was cancer treatment, and a tumor needs a blood supply for it to grow. And it was found that if you strangle the blood supply to a tumor or block it with what we call a monoclonal antibody to VEGF, that can actually shrink the tumor, and the tumor regresses and can die. So this same theory was applied to the eye, and that's why we have these anti-VEGF injections in the eye. We currently have a few anti-VEGF injections. The first one, which is actually used for cancer, was Avastin, which we can still use directly inside the eye. Then they started to make ones designed specifically for the eye. Lucentis or ranibizumab, Eylea, aflibercept came later, and Beovu or brolucizumab was one of the more newer developed injections. The mAb stands for a monoclonal antibody, and they're slightly different molecules with different sizes here. So VEGF is one of the main growth factors in angiogenesis and vascular permeability. However, there are others. This slightly pretty diagram shows the VEGF receptor on one of the endothelial cells in the body, but you can see there's other receptor and other sort of hormone pathways which may also be effective in blocking to help with eye diseases. So when we have macular disease, what are the goals that we try to achieve? Well, first of all, it's really important to prevent vision loss. Sometimes we can, sometimes we can't. Some of the early studies for injections show that about 95% of people had prevention of vision loss at 2 years, which is pretty good. We also have a goal of maintaining current vision. Improving vision is not always possible, but in the early studies, about 40 to 70% of people at 2 years could have some improvement in vision. We want a treatment which is minimally invasive, safe and convenient. So we don't want to have it so often. So many people who have treatment for wet macular degeneration with injections have treatment under what we call a treat and extend protocol. Now, what is this? This is basically you start treatment with a loading dose until the disease is stable. Then you gradually extend the time and find out when you can, how long you can go between treatment. So this little diagram here shows an eyeball with a blue layer of fluid here and an injection. And basically you treat at an interval until there is no fluid or it's dry. And then you, for example, you might be every 4 weeks to start with, and then you can go maybe to 6 weeks to see whether it's still dry, and 8 weeks maybe, but maybe at 8 weeks, the fluid might come back again. And then you need to say, well, that's a bit too long. Let's go back to maybe 6 weeks where it's dry again. And this is this individualized protocol or treat and extend. And often this is a very efficient way of treating wet macular degeneration with less visits but still good outcomes. So what about some people whose vision may not improve or stabilize despite having injections for wet macular degeneration? What are some of the reasons? Well, sometimes it's not enough injections. The disease may be very active or very aggressive, and sometimes you just need more treatment. Sometimes it's not the wet macular degeneration that's causing the problem, but other problems like increasing dry macular degeneration. We know that geographic atrophy can increase despite having wet macular degeneration treatment. We know that some people can get scar tissue or fibrosis. Sometimes the medications we have may not work, and we call it like a lack of efficacy. And there may be other eye conditions like cataract or dry eye or a corneal problem, which may be also a cause of why the vision may not improve or may deteriorate. So that's where we look for newer treatments for wet macular degeneration. So how do we know treatment works? It has to be done through a clinical trial, and there are generally 3 phases of clinical trials. A phase 1 trial is basically looking at whether the treatment is safe or not. Often it's the first time it's been used in humans after animal trials. If that's found to be safe in people, then it goes on to a phase 2 trial where you look at to see whether is the treatment effective or not. And this usually has more people, 100 to 300 people, and may take up to a couple of years. If there's some signal that there is some efficacy of the treatment, then you can go to a phase 3 trial where you're looking at comparing a new treatment compared to standard of care treatment. And this involves thousands of people and often is a multi-center international trial. And if that's found to be helpful after a phase 3 trial, then it can be approved in treatment, and hopefully then is being accessed to everybody, depending on where you live. So this is one of the newer treatments. Vabysmo is one of the newer treatments which is found to be helpful. So Vabysmo is a name which is constructed from VEGF-A, Ang2, a bispecific molecule. And basically it's helpful in two diseases at the moment. So wet macular degeneration, or NAMD, which stands for neovascular AMD, and DMO, or diabetic macular edema, O or E, depending where you live in the world. So we know that blood vessels are important in eye diseases, and we've got this pathway called the angiopoietin pathway, which maintains healthy blood vessels in our whole body. Think about having a garden hose which is nice and tight, and it's got no holes in it at all. That's because these little cells are maintaining the cell wall of the hose. Sometimes in diseases like diabetes or macular degeneration, you can get unhealthy blood vessels, and basically the Ang2 can switch on and off certain signal pathways which make the blood vessels very leaky. So now your garden hose starts to leak out water, and you can get these small blood vessels growing to the side, and this can cause weakening of some of their cells, increasing inflammation and damage. So it's often the damage from fluid and blood which can be the problem in retinal and retinal vascular disease. The thing about Vabysmo is it's the first antibody which targets both the VEGF pathway as well as the Ang2 pathway in a single molecule. So this is some of the data from the trials that we've been involved with. This graph shows along this horizontal axis time in weeks, and the top one is the vertical axis is vision. So we like to see when a patient has treatment that their vision improves, and we can see that this is the Tenaya and Lucerne study. These are the names of the trials, so that initially you can see some improvement in the vision across here, and it's basically maintained across for a couple of years. This was comparing the new treatment of Vabysmo in purple and a standard treatment, or Eylea, in gray. And in this particular trial, it showed that it was non-inferior or similar in terms of the vision, but with Vabysmo, there were less injections than the standard of care treatment at that time. So this is a useful slide showing that at 1 year, about 80% of people could go to have an injection every 12 or 16 weeks. In medical language, Q means every, so this is every 8 weeks, every 12 weeks, or every 16 weeks, using that same treat and extend protocol that was described before. If it was stable, you could go out longer between treatment, and they found that a lot of people could still get out to one injection every 3 or 4 months, which is quite useful. In year 2, it was similar. About 80% of people still had more than 12-week dosing, but the proportion of people who had every 4 months or every 16 weeks was higher at 2 years than in the 1 year. So many people, as you know, who have macular diseases need an OCT scan or an optical coherence tomography scan. This is a scan of the macula and the retina, which can show response to treatment and also give us lots of information about the macula. This is a patient not from this trial before, just showing that someone with wet macular degeneration with quite poor vision at 6/60, that's legally blind, had a large elevated bump here with fluid, and even after 1 treatment had some mild improvement, but after 6 treatments has flattened the OCT and with an improvement in vision to a level of driving. So this is the aims of treatment in order to reduce thickness of the macula. We often use that in clinical trials as one way to see whether the treatment is effective or not. So the next slide just shows the CST, or central subfield thickness, measured on OCT scan of the macula in these trials. So we start up here, again, time along the horizontal axis. So over time, you can see the thickness of the macula reducing over time and sort of maintained at a lower level. But again, with the Vabysmo, this could be done with 3 injections rather than 6 injections over 2 years. Well, what about other things? Well, the Eylea, which we've had for some time, and it is also a very effective treatment for macular diseases, has just been recently found to be helpful as well. We have a standard dose at the moment, which is a 2 milligram, but an 8 milligram one has been under trial in a slightly higher volume. And this was also found to have people able to be stretched out to a longer interval, at, again, 12 to 16 weeks, and about 80% of people at 1 year. So again, a sort of quadruple dose Eylea, which is not yet approved in Australia, but has just been found to be helpful in a clinical trial, phase 3 trial, and maybe also able to get people out longer between treatments. We've always thought that we know that injections can be helpful, but why not have some sort of device which you could put inside the eye, which you could just have a slow release of the medication, so people wouldn't need to keep on coming back in again having injections. So this system has been developed. It's called a port delivery system, or SUSVIMO. Basically, it's a surgical implantable reservoir which can be topped up every 6 months, and it allows a slow release of the medication in the eye. Again, this is not yet approved in Australia. I thought maybe you can think of it like a self-watering system for the eye. You'd like something which basically you could carry around without having to come back for injections frequently. So what is it? It's actually a little clear a flask which is put through vitrectomy surgery into a corner pocket of the eye, and then stays there long term. And this can be then refilled through a special type of injection into the reservoir, and that you can put a larger volume than you would normally be able to put with a single injection that we currently have. There was a phase 2 trial called the Ladder study, which showed that if you had a dose of about 100 milligrams per mil, patients gained about 5 letters in 9 months versus about 4 letters with an injection every month, and they needed maybe a refill every 15 months or so. Some of the earlier results did show some side effects, mainly due to some of the initial learning with surgical technique, but in the phase 3 Archway trial, that was found to be much reduced due to some changes in technique. So this trial had people coming in having already had injections before, so we don't often see an improvement in the chart here in terms of the numbers here, but this is a graph with the grey being monthly injections, and the black is the port delivery system. And basically, the port delivery system was topped up every 6 months, and it showed sort of non-inferiority, so kind of similar vision across the duration of the trial. And this results was about 40 weeks. And again, the OCT thickness was also similar, that it didn't show much of a difference. But the port delivery device was topped up every 6 months, whereas the other arm had to have monthly injections. Was FDA approved in the US in October 2021. However, unfortunately, it had a voluntary recall in December 2022 due to some technical issues with the vial. There seemed to be a small issue with some of the septum, or the separating area here, which allowed some leakage of the drug out. So this is the device when you can see inside the eye like that. So it's a nice concept, but again, as with anything, there's sometimes there may be things which need to be worked out along the way. So what about other molecules? This is another study. It's an Australian company doing some research in the macular space. Opthea, based in Melbourne, OPT302. We're currently involved in this trial as well. Basically, it's trying to target other VEGF molecules. One of the primary molecule we know is VEGF, but there's slightly different variations of VEGF. This is VEGF-A, which the current range of treatments are involved with here, but VEGF-C and VEGF-D may be other targets that could be useful to use together with suppression of VEGF-A. So some of the early studies, the phase 1 or 2 studies, showed some improvement and improvement thickness in previously treated eyes. and the phase 3 trial, or the COAST trial, is currently underway at the moment for patients combining a VEGF-C inhibitor with VEGF-A versus purely VEGF-A. So we'll see, it'd be interesting to see what the results show from this. Other companies have been looking at sustained release implants. This is the KSI 301 study from Kodiak, basically linking an anti-VEGF molecule to some sort of polymer, which was theoretically allowed to have dosing every 3 to 4 months. Unfortunately, some of the results here were not so favorable. This graph shows in the purple a aflibercept or Eylea given in an appropriate way, but the blue new trial product didn't seem to achieve as effective results as the standard treatment, and therefore did not meet its endpoints. So I guess with many trials that often patients can sometimes have the treatment of the new trial product or versus the standard product, and not all trial products can come to fruition. Other products being looked at are things like tyrosine kinase inhibitors, or TKIs. These also block different types of cells, which can lead to leakage or blockage inside the eye. These are also based on cancer treatments as well. This is another sustained release device which we've been involved with, the Ocular Therapeutics trial. Again, it's like a very small hydrogel implant which goes inside the eye and can be slowly released over time, and releasing the drug as well. This implant can target certain VEGF molecules and is thought to maybe release the medication in about 6 to 12 months. What about gene therapy? A lot has been talked about gene therapy in the news for various things. Gene therapy, when we think about it in general, is basically finding that somebody has an abnormal gene, and then finding the healthy gene, and then putting that healthy gene back into the person to make the cell work again. And these are often done through these things called viral vectors. It sounds a bit scary having a viral, but these are harmless viruses which basically are very good at getting genetic material into cells. Hence they're called vectors. So it was always thought, well, maybe can we try to permanently switch off some of this VEGF secretion in patients with macular degeneration. And there's a few ways to approach this. One is to put something which silences the VEGF gene, or something which may promote hormones to suppress the VEGF gene as well. This is one way to approach it in terms of putting the injection rather inside the eye in what's called the vitreous, into a space underneath the retina, called the subretinal space. This is one company called Rexgen Bio. We've got a product basically trying to make the retinal cells produce anti-VEGF by themselves, and it's found to reduce leakage of blood vessels. This is again in early phase trial, not approved yet, but it's a very interesting concept in terms of trying to get your own cells to make its own anti-VEGF product. Again, this is given through not a normal injection which goes into the vitreous space here, but underneath the retina, usually through vitrectomy procedure, where you can deliver the gene therapy directly to where the cells are needed. This is another company, ADVM22 at Viren Biotechnologies. Again, a similar process, trying to get a similar, like a viral protein, viral element, which is making its own aflibercept. Basically, this little program releases aflibercept inside the eye as well. So it's basically putting this inside the eye and then getting the cells to make their own anti-VEGF injections. So it's a bit like having a little factory in your own eye, or making Eylea by itself without having to have other injections inside the eye. So again, very interesting concepts, and we'll see some results coming through over the next couple of years. So how do we get in medications inside the eye? Well, at the moment, we use something we call an intravitreal injection. The vitreous is the jelly inside the eye, and the medication goes in here and starts to work on bleeding and blood vessels here. We've just spoken about a subretinal approach where we can put it directly underneath the retina here in a little bubble. But there's other ways, what we call a suprachoroidal approach, where we go from the outside rather than from the inside, which is another very interesting idea. So there's a space between the white, tough part of the eye, called the sclera, and some of the underlying blood vessels here, where you can, if you just find that right space, you can just put some medication in there, and that kind of trickles right into the space where you want it as well. This is a special needle going into that space there, and it's even been trademarked, that space, by a certain company, and this is the injection here, just going into that space directly there. So it's a very another clever way of trying to get a medication to kind of where it may be more effective. What about dry macular degeneration? So we talked about before the progression of early to late dry macular degeneration, and currently there is really supportive treatments for dry macular degeneration. We don't have any really good treatments for that. What do we do? Diet and lifestyle are really important. We should be eating more leafy green vegetables, more omega-3, more fish. We should be exercising, wearing sunglasses. We should stop smoking if we smoke. There are some antioxidant vitamins there available. We call the AREDS, or age-related eye disease study, or the AREDS2 recipes. These can slow down types of dry macular degeneration from the intermediate to the dry type, to the advanced dry type, but it does not slow down the geographic atrophy. So we have different brands. Blackmore's have a brand called MacuVision. Just remember, if you're on MacuVision and have normal dry macular degeneration, the dose is actually 2 a day rather than 1 a day. So please check with your eye care professional about this. 1 day, it's not allowed to put the normal dose because of the amount of zinc in there. The AREDS2 recipe has, in a daily dose, a bit less zinc and some called lutein in it, and the products available, common ones, Blackmore, MacuVision Plus, MacuTech, and MDIs in Australia. So these can, again, slow down some of the intermediate, but it does not slow down the geographic atrophy. This is what we call a normal autofluorescence scan of the retina. The retina is normally a nice medium grey colour like this. These pictures show what can happen with geographic atrophy over time. And you can see on the left, the baseline, this is a person who's had a few grey dark spots there. Once these spots become black, they're basically missing and we don't get them back again. And if they're in the middle part of our vision, we can imagine that our vision can be quite reduced. So if you see baseline from 2 years to 5 years, this black area is basically steadily increasing. We have no ways to slow that down up until recently. So I tell people it's a bit like having a threadbare or moth-eaten carpet, and we don't have any treatments for it. This is what somebody may notice on the AMS grid. This is the waviness and bits missing. So it's a very important problem because it affects a lot of people. It's thought maybe 5 million people around the world might have geographic atrophy, which is vision threatening. And often these areas increase in size by about 1.5 to 2 millimeters square per year. There are certain risk factors for this type of geographic atrophy as well. So what's new is that there is actually a new phase 3 proven treatment for geographic atrophy. The trade name is Syfovre or pegcetacoplan. At the moment, it's an injection every month or every second month of a medication. And this was found to slow down geographic atrophy progression by about 16 to 22% over 2 years. This has been recently approved in the US, but not reimbursed, but not yet approved in Australia. But it's the first, one of the first medications to be proven to slow down geographic atrophy. So it may be exciting. Hopefully we look forward to have the access for patients hopefully next year or the year after, but we really don't know. I think this is where advocacy through the MDFA and for patients and for the community to help lobby for supportive medications such as this can really make a difference in the long term. Why is this helpful? Look, quite a few years ago, around the world, it was found that one of the genes called the complement factor H gene was causative in many people with macular degeneration. The complement gene is part of the immune system. So we know that the immune system is important in causing macular degeneration. Because of that, a lot of people started working on possible things which could target these pathways. And some years later, we now have treatment pegcetacoplan, which basically switches off some of the pathways of complement to prevent this causing dry macular degeneration in some patients. So this is the complement system, part of the immune defense, and we can see that we need the complement to defend us against viruses and other external insults. But it's also important for our internal immunity as well. So this is some of the results from the trials, the OAKS and Derby trials that we've been involved with over the last few years. And basically showing, again, this is time across the horizontal axis, and this is change in the lesion size. So that means that basically as we get older with geographic atrophy, basically the black spots can get bigger and bigger with this gray line here. PM's every month, PEOM is every other month injections. And we can see that at 12 months, there was a bit of a difference between those people who are having treatment and not treatment. Basically, it tends to slow down the lesion growth. So you can see at 2 years, about 20% of people had reduced lesion growth at 2 years, which in some patients would be a significant amount. So again, we try to slow down this black process happening. What about some other early phase drugs in development for dry macular degeneration? We've always been looking for tablet versions or eye drops of some of the treatments we put inside the eye. And there are 2 trials on the way at the moment that we're involved with, the Onward study from Alexion and the Phoenix study by Belite Bio. Again, one looking at complement factor D to try to do the same process, the injection, but in a tablet version. And the other version is a vitamin A inhibitor, again, to try to slow down with a tablet as well. So this would be the ultimate goal of something to have a tablet, perhaps, rather than a injection. But again, sometimes tablets need to be a lot stronger to get to the eye, whereas having a treatment inside the eye is often gets the treatment directly to where it's needed. Finally, I'd just like to speak about diabetic macular edema, which is another vision-threatening macular disease. This is a patient who has macular edema. You can see instead of that healthy retina I showed you earlier, this patient has lots of yellow stuff, which is sort of exudates or fatty deposits in the macula, some red spots, which is blood. When we do the OCT scan, we can see a lot of swelling here. So macular edema is swelling or waterlogging of the macula from leaky blood vessels, and this is definitely not normal here. But we can do things for patients. This patient went from a yellow, all this stuff on the left to the right here over 6 months. And how did he get there? He actually got his diabetes better. We also needed to do some injections and some laser treatment on him. And luckily, his vision improved. So there's some patients who we can improve if it's not too far gone. So what do we do to treat macular edema? There are systemic or body treatments and then eye treatments. Systemic treatments are really improving the diabetes, and it's really crucial to get the sugar levels under control. We know that controlling blood pressure is important. Fenofibrate or Lipidil is a cholesterol tablet which can lower cholesterol. It was found a little while ago to be also effective in diabetic macular edema. And it was thought that to be working outside of the mechanism that it works with cholesterol. So for those people who don't know about this, please speak to your GP, your eye care provider, and your diabetes clinic or endocrinologist to see whether you may be appropriate for this as well. In terms of the eye treatments, we have injections, laser, and sometimes surgery to help diabetic macular edema. What are the current eye injections that we have? Avastin is still used, Lucentis and Eylea. We also have Ozurdex, which is a dexamethasone implant. This is a type of cortisone or steroid which can be slowly released over 3 or 4 months and can also reduce the need for injections and can be used as an adjunct or as a primary treatment of diabetic macular edema to some effect as well. What's new on for DME? Vabysmo has also been approved for DME, and this is the trial looking at, they have funny names based on rivers and geographic locations. The Yosemite and Rhine study looking at Vabysmo against standard aflibercept treatment. And again, it was found that everybody, all the groups seemed to improve vision. There was no real difference in terms of the improvement in vision between Vabysmo and Eylea, but it was given with perhaps less injections, and about 80% of people could be treated at 12 to 16 weeks after 2 years. So again, trying to extend the treatment to longer. This is just some graphs showing some improvement again in the OCT scan thickness, both arms reducing. Perhaps there was a slight favor in terms of the Vabysmo here at a couple of years out in the light blue and dark blue compared to the gray, but again, having both treatments very effective. So what about other treatments? Again, Eylea or aflibercept in the quadruple dose has also recently been shown to be helpful in about 90% of diabetic macular edema patients and can be maintained on 12 to 16 weeks as well. So there's lots of happening in terms of diabetes as well. So in conclusion, look, we have effective treatments available for some macular disorders. However, outcomes and treatment burden could be improved, and we always welcome new and emerging treatments. Some macular disorders we have are still untreatable, but it is important to have early detection and treatment to prevent vision loss. So please contact your eye care professional and to consider being involved in clinical trials. I think it can be quite rewarding in many ways to help others contribute to science and help yourself a lot of the times. We are grateful for all the patients and teams who have been involved in clinical trials over the years. If you're interested in trials, please contact the MDFA. If you're in Sydney, we'll be welcome to see you at Strathfield. Some contact details I'll leave later. But it's good to be aware of what's happening around. So I'd like to thank you for your attention today, and I'd just like to thank the MDFA again of the invitation. And if you have any questions, please go ahead and ask.
Perfect. Thank you so much for that, Dr. Wong. That was unbelievably informative. I was jotting down notes myself, and I'm sure other people in the audience was as well. Before we get to the questions, I did want to give everybody a quick reminder of how they can send their questions through. So again, that little black strip at the bottom of your screen, you can select the Q&A icon. And then when you click on that, it will bring up a white rectangle. You can type your question in at the bottom before selecting send. And again, you can send that in anonymously if you would like to do so. Before we get to the questions, I wanted to talk quickly about the Macular Disease Foundation Australia. We have a goal to try to reduce the incidence and impact of macular disease, and we do this through our 4 pillars. Our first being prevention and early detection. So we do talks such as this or face-to-face talks where we try to increase the awareness of macular conditions. We spoke to over 7,000 people last year, and we're hoping to do a similar amount this year as well. Support and services. So we support the entire macular disease community, whether it be patients, family members, or even healthcare professionals. I'll talk a little bit more about this in a moment. Voice of the macular disease community. So it's our privilege to advocate on behalf of the macular disease community, whether it be designing state or federal policies, or as James mentioned, excuse me, whether it be advocating for the approval of new drugs or making sure that medical benefits are not cut. And finally, research and data. So 100% of funds donated to research goes directly into our research grants program. So this is where we can help those clinical trials. And since 2011, we have given a massive $5.7 million to 29 different Australian research projects. Speaking of support, if you do have any questions, not just about what we heard about today, but if you have other questions, general questions about age-related macular degeneration, diabetic eye disease, other conditions, you're very welcome to contact us. We can also help you with things like government services, My Age Care, Medicare, rebates, all of that we can provide support with. And you can ask those questions either by calling our helpline, which again is 1-800-111-709. You can email us at education@mdfoundation.com.au, or you can pop on our website as well, which is www.mdfoundation.com.au. And just a reminder that absolutely everything we provide is for free. Now, at the conclusion of this webinar, you will be receiving an email in your inbox, and that email is going to have a handful of links. The first link will be to a survey. If you could fill it out, that would be really great. There's only a few questions on there, but it does give us an indication of how you thought this webinar went and what we can improve in the future. You will also receive a link to previous webinars that have been uploaded and recorded, so you can watch them later, as well as a link to any potential future webinars that we have coming up. Because this is a webinar focused all about research, you'll also be receiving a link to our latest research update, and a lot of the drugs and trials that Dr. Wong spoke about are actually in the research update as well. All right, so we have, oh gosh, we have quite a few questions coming in, which is great. So we might start with some questions. All right, let's take a look. Okay, first question. How many loading doses are usually needed for the eye injections?
Right. Look, a very good question. It does depend on what you have and who's what your treating eye specialist thinks to do. We often load people with an injection every month, often say for 3 injections, and then we can assess after that. We're very fortunate in Australia to have certain guidelines in terms of what we're allowed to use in terms of treatments. For both wet macular degeneration and diabetic macular edema, often we use this treat and extend protocol. So it may load people with injections, 3 injections, sometimes maybe 5 for diabetes, and before seeing whether there's a response. Sometimes it can take a little while to see a response. It may not be an immediate thing. It can take 6 to 9 months sometimes to see any response in patients with diabetes. And so it does depend on what you have. There's some people who may not need a loading dose at all, may just have an injection and need to be seen and see how it goes. So it's something that you should be speaking to your ophthalmologist about just to be informed about what is best for you.
So it very much depends on the person.
Does depend on the eye condition.
Can you have dry and wet macular degeneration at the same time?
Yes, good question. Yes, you can have both dry and wet macular degeneration at the same time. Sometimes, if you saw the slide there, you've got this progression of the sort of early to intermediate to advanced dry macular degeneration, and sometimes along the way you can have the offshoot of the wet macula, but it means you've still got some of the dry macula as well as the wet. And again, people can have good treatment for the wet macular degeneration, but still have problems with their vision. and it's not because it's not been adequately treated, but the dry macula can progress. So yes, you definitely can have both wet and dry simultaneously.
The next question we have is, I'm currently receiving Eylea injections. Vabysmo sounds very promising. How can I receive it? Do I have to ask my ophthalmologist?
Yes, look, it's nice to have access to newer treatments, and we're very fortunate in Australia to have access to many of the latest treatments available in the world. With Vabysmo, definitely speak to your ophthalmologist to see whether it's appropriate in you or not. There are many people who are already on Eylea, very happy with their treatment, and they're at already 3 months or 4 months or 2 months, and there's no need to change. The people who maybe may benefit from a change or a new medication, maybe people who perhaps are on 4 weekly injections who have still got fluid, or there's deteriorating vision, which might indicate an aggressive type of wet macular degeneration or diabetes. So definitely speak to your ophthalmologist to see whether this is appropriate in you. But may not be appropriate in some people, but others, yes, they would may benefit from them as well.
Sure. The next question I might actually take, Dr. Wong. So the next question is whether this webinar will be available afterwards. Yes, so this webinar is being recorded right now, and once it's edited, it should be available on our website. And like I said, you will be receiving a link for that in the email sent at the end of the webinar. So the next one again would be for Dr. Wong. So can laser treatments be used to manage macular degeneration?
Really good question, that one. I haven't really mentioned that along the way. In the old days, before we had injections, we used to have lasers for wet macular degeneration. There was a laser called a PDT, or photodynamic therapy laser, which involved a special dye and then a laser. And that was moderately effective, but has been now surpassed by the injections. However, for some types of wet macular degeneration, lasers still may be appropriate. There's a subgroup of wet macular degeneration called a polypoidal choroidal vasculopathy, or PCV. And some patients who have this have a type of bleeding which may actually respond to types of laser or in combination with the injections. In some people, they can have a type of thermal laser for wet macular degeneration, but again, the injections are really, for the majority of people, injections are still the best thing. In terms of the dry macula, there has been some research about using a type of what we call a subthreshold laser, or a very gentle laser, to see whether it can shrink some of the drusen and again reduce the chance of progressing to more advanced dry macula. There's some interesting results coming through. It's not completely proven yet. We still need to wait for phase 3 trial to show any benefit. So it's not a standard recommendation now, but we know that there is some interesting effect that laser can do to shrink these spots and to maybe reduce the chance of progression. So lasers for wet and dry macular degeneration are not out of the question completely, and so we may hear more of this in the future. But again, you speak to your ophthalmologist to see whether there's any, if you have macular problems, to see whether this is appropriate in you.
Oh, perfect. With slow release, or I'm not going to say the right, dexamethasone, does this present a problem with acquiring glaucoma?
Very good question. Look, dexamethasone we put inside the eye for some conditions like diabetic macular edema or inflammatory eye conditions. It's a type of steroid. We know that in some people, a steroid can cause pressure rise in the eye, which can lead to glaucoma. Glaucoma is optic nerve damage, which can sometimes be associated with high pressures, but not always. So people who have dexamethasone, we do need to be aware and careful about watching the eye pressure. Interestingly, about 30% of people, if you put them on some sort of steroid or cortisone eye drop can have a pressure rise in the eye. So we know that's perhaps an individual thing. It can be managed if dexamethasone is still an effective treatment for diabetic macular edema. The pressure can be managed, and patients need not always develop glaucoma from the dexamethasone, but it's something that your ophthalmologist should be aware of, and it is well recognized to watch out for pressure. So in answer to the question, it's not usually a problem in everybody getting glaucoma from having dexamethasone, but it does need to be watched.
Okay, perfect. And this might be the last question for today, if that's okay, Dr. Wong. So I have, how often should you have an eye check by an ophthalmologist if you have a family history of macular degeneration?
That's a good question as well. I think that we know that macular degeneration can be hereditary or passed down through the generation, but not always. It does. We do recommend family members have their eyes checked. May not always need to be by an ophthalmologist, can be an optometrist. I think having the OCT scan is a very useful technology now, wherever you go, to just make sure that an OCT is done, because it's one of the best ways to see whether there is any macular problem there. If it does depend on what you have. If a family member has a perfectly healthy and normal macula, then you can probably say that there's over the next couple of years, it's probably lower risk of developing certain macular problems. However, somebody should be probably checking it at least every couple of years in terms of making sure that still stays a low risk. If there is signs of macular degeneration in a family member, yes, this should be monitored appropriately. Sometimes we monitor people once a year. If there's, it does depend on what you have. If there's a high risk area, then sometimes we monitor people, every few months or so, just to make sure there's no change. That it should be done at a baseline, I think, and then after that, just depends on what you have. Over the age of 50, we should all be having our eyes checked by someone at least every once or twice a year, 1 or 2 years, basically, just to pick up for any other eye diseases as well.
Yeah, perfect. Well, I think that brings us to the end of our questions. For those of you who sent in questions that we couldn't get to, I do apologize. However, we will endeavour to reply to those questions, because we do have your email, so we'll send those answers through. Dr. Wong, thank you so much for joining us today. That was extremely informative, very, very interesting, and it's really exciting to see, what all the research has in store for the macular community. So thank you very much. We really appreciate it.
It's a pleasure.
Thank you.